Good morning, everyone. I'd like to thank you for attending today's webinar, Lean in Healthcare, a look into the future with John Kim, President of John Kim and Associates. A quick reminder that these webinars are provided by the Shingo Exchange, the Operational Excellence blog of the Shingo Prize for Operational Excellence, under the direction of the John M. Huntsman School of Business at Utah State University. If you are not registered as a member on the Shingo Exchange, you should do that right away to get great articles and webinar recordings about all things operational excellence. The Shingo Exchange Operational Excellence Engaged. www.shingoexchange.com. Also, don't forget that the 25th Annual Shingo Prize International Conference will be held May 6th through the 10th, 2013 in Provo, Utah. This is going to be our best conference ever as it is our 25th anniversary. We're so excited for it. We have special things planned for this conference that you're not going to want to miss at all. At this time, I'd like to introduce today's presenter, Mr. John Kim. John Kim is an internationally recognized leader in the design, development, and mobilization of enterprise-wide lean transformations. As an executive at the Hahn Company and Danaher Corporation, John learned the keys to implementing lean while running multiple operations across the U.S. in the 90s. With over 25 years of experience, John has become an internationally recognized speaker on lean leadership, lean healthcare, and enterprise-wide lean transformations. With speaking engagements spanning 6 continents, John has been a keynote speaker at both public conferences and private companies alike. John has spent over 15 years in executive consulting, specifically helping organizations align, mobilize, and implement lean in sectors including healthcare, health plans, medical devices, pharmaceuticals, manufacturing, and services distribution. If you have questions during the presentation, please type them in over in the questions bar on the right of your screen, and we will address them at the end of the presentation. I will now make sure that we can all see Mr. Kim's screen.
Joby, thank you very much for the introduction, and I just want to second the type of learning and knowledge sharing that the Shingo Prize offers, right, through their various workshops and forums, and certainly the annual conference. Also, just want to thank everybody for taking the time out of their day, for many of you during your lunch hour, to spend some time sharing some lessons learned, primarily about lean in healthcare. But also some shared experiences just going back to even the early days in the early 90s. One of the biggest things about lean in healthcare is the degree of change that's affecting the industry. And whether it be learning and applications of lean and lean principles, whether it's the evolution and learning about culture and mobilizing change, or whether it's dealing with situations or realities such as the shift from fee-for-service to shared risk. These are all aspects that are coming fast and furious into healthcare. During the next 30 or 35 minutes or so, I'm going to share with you some slides, obviously. I really emphasize, right, some of the key lessons learned. I always talk about, things I wish I had known when I started learning this stuff in the early 90s. And also specifically things I wish I had known when we started doing lean healthcare back in 2003. So we'll try and cover some of those bases as we go forward. And again, if you have any questions, please feel free to type them in, and Joe will lead us through that at the end of the session. A little bit of our topics for today. I want to talk about the Shingo model and its relationship with OpEx and healthcare. OpEx is a brand owned by the Shingo Prize. And how the Shingo model fits nicely with lean in healthcare specifically. Next topic we'll talk a little bit about is lean in healthcare, adapt versus adopt, and again sharing some of the lessons learned as many of us started taking lean manufacturing principles into healthcare, and I'm trying to share some of the lessons learned over the last 10 years, as well as some of the most common errors that we see even going on today. The third topic is I call the patient-centered medical home, PCMH. Really, that's intended to talk about some of the shift or the change in thinking with regard to reimbursement models and the notion about managing health versus caring for illness. And what does it really mean when you think about the entire value stream? Interesting topic there, just with regard to value stream, is there's a time for many years where I thought the healthcare value stream kind of evolved around hospitals. Over the last 3 or 4 years, it has very clearly expanded to include not just hospitals, also the downstream skilled nursing facilities, the SNFs, also the specialists, also primary care. And the real kicker to the puzzle is health plans. And how does understanding health plans influence your perspective of seeing the healthcare enterprise? I can tell you from our team's point of view, our lessons learned over the last 3 or 4 years have been, it's fundamentally changed how we look at the role of hospitals and the mobilization of lean. The last piece I mentioned, just the evolving reimbursement model. What does fee for service to shared risk mean, right? And more importantly, what does it mean to your providers, your practices? What does it mean to the communities served by various hospitals? And again, I'll look into the future. And then we'll end with some Q&A. My plan is to try and leave 15 to 20 minutes at the end of the webinar to answer any questions that there might be. The first 6 or 7 slides here actually come out of the Shingo Prize, and I just wanted to talk about the imagery associated with this particular slide. We all know the proverbial lean journey, right? And that it takes quote unquote years to get there, and over time you learn more, and all the dialogue around peeling the onion as you learn one lesson, more lessons get exposed and things like that. One of the things that we really want to emphasize, particularly in healthcare, is the phrase lean is a learn by doing process, and how in manufacturing we use that phrase all the time. But we believe in healthcare that phrase is actually overused. It's overused to the point where it sounds like one can only learn by doing. And in reality, right, the types of wastes that we all find in healthcare, the type of opportunities that we all see in a hospital, right, or up and down the value chain, are actually very repeated wastes, right? They all sound very similar, right? So the notion of one can only learn by doing, and that I perhaps learned how to solve the problem of patient wait time in ED, right? That those lessons somehow cannot be shared or scaled across patient wait times in CT or in imaging. Is actually wrong, right? So we'll talk about some of that. Those who have walked the journey before in hospitals or in healthcare, they have many lessons that are learned, right? Many things that they can share, and many experiences that don't have to be learned over and over and over again by those that follow. So we're going to talk about that quite a bit. The other piece is the notion of the bridge. And maybe the concept that there's more than one kind of bridge. So that's another key piece too, particularly associated with healthcare, and that's the phrase that one size doesn't fit all. There are no formulas that should tell you what you should and should not do, how fast you should go, or where you should begin. Whether you're a critical access hospital or whether you're a 800-bed academic hospital, right? Your challenges, your opportunities, your culture, your current capabilities as an organization will all affect what you choose to work on and how fast you can go, right? So keep the notion of the imagery of a bridge in mind, and keep also a perspective that there's not one kind of bridge that fits all situations. We'll talk more about that as we go on. This slide right here, just wanted to emphasize the 3 things you see down at the bottom, right? These are probably the cornerstones of the Shingo Prize that most people are familiar with. And I just want to emphasize that if you're not too familiar with the prize, do take the time to go to the website, go to the conference, attend the workshops. The Shingo Prize team has done an incredible job of capturing the lessons learned from many, many industries, and again, particularly healthcare, right? And in the house, the one on the left, right, they capture the what. The circle or the pie in the middle, or the pizza in the middle, is how they captured the who's. And then the diamond on the right, is a great representation of the how. And so, if your team's struggling, or if you're wondering about, how do you go about this? Where do I begin? My organization's large, right? Not everybody's at the same place. I can't urge you enough to look at the Shingo model and see the types of things that they've captured and see if that helps you along the way. This slide as well, if you look at the left, understanding and insight, right? So obviously here we have our mountaineer starting on his journey, and as that individual, who in essence is you or your organization, as you have an increasing and understanding and insight, right, comes right the opportunity to learn more and accept more. One of the key things that we talk about is the notion of with awareness comes the opportunity to learn. With learning comes knowledge. With knowledge comes capability, right? And each of those things play on and on. From capability, you can start to execute an improvement process, right? We call that mobilization. From mobilization, you can talk about implementation. From implementation, you can talk about deployment, right? And with deployment, you can start to see performance results. These are the different steps, right, that are key to learning. Some of the mistakes made in the early days, I shouldn't say the early days, they're still common mistakes today, is to focus too much on tools, too much on metrics, and too much on results. And in doing so, you may achieve the result, but you don't build the fundamental process. If you don't build the process, you've lost the opportunity to learn. It could even be worse than that, in that you may have learned the wrong methodology, or perhaps the methodology is not scalable. When we look at the slope or the learning curve associated in an organization, as change agents, as senior leaders, you absolutely can influence the slope of that curve and the direction of that curve with an appropriate structure, with an appropriate approach, with a strategy for communication, with an awareness of culture. You can definitely influence the velocity at which you go and the degree of impact in which your organization sees results. So just keep both pieces in mind. This is a slide that, probably 2 years ago, Jake Raymer, myself, Jen Griffith, and Vinny Polito and I were drawing at the Shingo Prize. And one of the things that we talked about, right, was some of the struggles that are going on, and it's particularly been witnessed by the Shingo Prize with their achievement reports and site visits and the types of workshops that they do. And it's very, very common, right, for organizations to start their lean journey with the notion of doing things like you see right here, right? So we will use tools, we will do events, we use VSM, and we get results. The challenge is that eventually most all organizations come to the question of, isn't there more? Our results aren't stable. We struggle with sustainment. We're working really, really hard to achieve buy-in. And so although the typical starting points may deliver short-term results, there's a serious question with regard to what's sustainable, what's scalable across an organization. Maybe a quick example right here that I use all the time was I was meeting with a couple executives running a hospital system in Florida. And one of the things that they had sent to me was a very good case study talking about great success in one of their EDs. And it was a very, very good case study. In talking to the CEO and the COO, one of the questions I asked was, you have a great example of some tremendous success in one of your hospitals. How pleased are you with the lessons that were learned in the ED being shared across the other floors or the units in the hospital? They both looked at each other and they said, yeah, to be honest, John, no one's really done anything. And I said, okay, that's not a surprise. Let me ask you another question. All right, you have 10 other hospitals in your hospital system. I suspect you have at least 10 other EDs. How pleased are you, or how satisfied are you with the other 10 EDs taking what was learned by their own cousins and starting to capture and share and deploy some of the solutions that work so well in one part of the organization onto the other? And they both looked at each other and gave the same answer as well. Yeah, no one's done a thing. All right, so one of the things that we talk about, and one of the lessons learned about lean in healthcare, is we use the phrase, it's not good enough to quote unquote merely be good at lean. The notion of scalability, the notion of knowledge capture and knowledge transfer are key components. If you can figure out a process for capturing what was learned and sharing what was learned, then you reap the advantage of everybody not having to learn the same mistakes over and over and over again. So that'll be one of the themes that we talk about as we go forward as well. Eventually, what we want to do, obviously, is build a bridge, which is more stable and allows us to take on whatever challenges we have in the organization. And we'll come back to that here in a little bit as well. Embedded in the pillars, right, is a bit of a correlation between the Shingo Prize, right, and what we call the pillars, right, or the stanchion for the bridge itself. And you can see that for yourself, right? At the base, obviously, is culture, continuous improvement, enterprise alignment, and results, right? That's pretty logical. Something that's not always so logical is the notion that depending on your starting point in terms of where you are, the strength of your culture, your current capabilities for continuous improvement, in order to achieve the pillar on the right, may not be from the bottom going up, right? And so how you approach building the end result is not necessarily logical or in sequence to what you see in the pillar, right? So we'll talk about that as well. Hold on a second here. The next piece I want to talk about is a little about adapting and adopting, right? Lean principles in healthcare. I could actually do this entire webinar on this slide alone, right? So here's some key points, right? Healthcare is still a relatively new application of lean. Because one has been doing lean for 5 years in the organization does not necessarily mean they have 5 years of experience. They may be repeating the same basic steps over and over and over again for 5 years. Remember too that the early applications of lean, or lean in healthcare, adopted lean from other industries, in manufacturing as an example, right? And there are many nuances of your industry in healthcare, obviously, that are very different than what goes on in manufacturing. One of them, obviously, is hospitals are far more complex. Multiple sites are the norm. You know, in a typical healthcare system, you may have 2 or 3 hospitals. We like to use the phrase, a hospital is not a hospital is not a hospital. The mobilization approach, the lessons learned, and the approach that you use for a critical access hospital is going to be very, very different than the approach you might use for an academic hospital. We use the notion of the learning model. It's very, very different, right, in healthcare compared to other industries. This is a learn by reading process. This is a culture. This is an education culture. This is a culture or an industry where reading things and capturing lessons learned and being able to absorb them actually is pretty common, right? So a lot of the you can only learn by doing dialogue, right, should be challenged. Just think about healthcare. The other piece too is healthcare is not just hospitals, right? As I said earlier, right? There's downstream SNPs. Inside the hospital, you have a whole myriad of process flows. You have specialists, you have PCPs, you have medical devices, right? And then you also have the health plans. And the last piece there is kind of what I said earlier, right? Lean in healthcare has yet to realize the importance or the value of learning from each other. Many of the things that I was taught from my Japanese sensei, right? This is a dirty hands process, John, right? You must learn by doing, John, right? May have been appropriate in one industry, but do not have to be blindly applied to healthcare as well. The notion of one size does not fit all is key. There's a phrase that we use, and we call it the pace of change. Depending on your organization's objectives, depending on your culture, depending on your current organizational capabilities, right, how experienced you are with improvement and managing change, the pace of change that you can go is very, very different from organization to organization. Your business objectives, in one hospital, it may be about patient safety, it might be about quality of care. It might be a financial situation, depending on your objective, depending on your culture, depending on your current capabilities, right? How you approach how fast you should go, how fast you can go. Those are critical inputs, right? So we like to say, for those that like to apply a formula, right? I guess the formula does not need all the other inputs of your organization to decide, right? What is the appropriate velocity? What is the appropriate focus? So think about that as you think about your organizations as well. Here's a slide, right? So all of these organizations have been written about in various shapes and forms, right? And the point here is they've all been successful with lean in different ways, right? They've all felt they've used lean appropriately to achieve their objectives, right? So once again, right, as you think about your team, your senior leadership team, the degree of commitment you have, or you're working with, the business challenges in front of you, right? Your methodology approach is going to be very different. I get asked at almost every conference I speak at, right, my definition of lean. And so you can see it down at the bottom here, right? What I describe is very simply, lean is not about doing what you do today and doing the same things faster tomorrow, right? Lean is a methodology, right, that helps us look at our processes and helps us understand why we have to do the things that we do today. Our goal is to try and identify where in the process we can make an impact, right? Or if we change something, almost always upstream in healthcare, right? In the future, you won't have to do as many things as much. And those are the blocks of time that we're after to try and give back to the care providers and the care teams, right? So, very simply, we like to ask the question from an information point of view. What percent of the time does the information arrive complete and ready to go? No hunting, no fetching, no emails, no phone calls, right? In healthcare, it's difficult to hear an answer greater than 70%. Most are under 50%. Right? So in this context, the goal is not to figure out how to hunt, fetch, and chase faster. The goal is to try and understand why we have to do so many callbacks and get so much clarification, and where in the process can we make that impact. Where to begin? We always say start with a business objective. Understand why you're doing lean. Right? From there, you can identify the processes of the value streams that impact that particular metric. We're beginning to create some focus. Right? Senior leadership, what's important to us? Director, what's important to you? Frontline manager, what's important to you? Right? Based on what's important, we can start to identify the critical value streams or the processes that align with or impact that metric. Now we know we're working in the right areas. From there, we can talk about identifying and eliminating waste. Right? This is what people tend to think lean is. Right? There's just a front-end piece that should go with it. As you appropriately identify and eliminate what we call the right waste, you can start to build processes that flow better than they did before, right? And it is that creation of flow, right, that you start to get performance improvement. There's also an interesting another advantage as well, and that is as your organization begins to learn how to focus, align, mobilize, implement, or design and implement solutions, they start to build an internal capability to be able to do this over and over and over again. So this is something interesting about manufacturing and healthcare. In manufacturing, right, pick the number, there's 100 tools, and you might have to use 100 of them. In healthcare, the quantity of tools that we use to solve the majority of the problems we have sounds like 10, sounds like 8, sounds like 12. Right? So as you stand back and you think about training your teams, is the objective to train them on more tools or train them on the right tools to a higher degree of knowledge and capability, right? So the exciting thing about healthcare is that the breadth of learning, the quantity of learning does not have to be so high. However, what becomes key is your ability to implement and deploy. And that's one of the key lessons we'll be talking about here as we go on. Typical waste in healthcare, right? Take your pick, right? And one of the things that we like to say, right, is finding the waste, right? Identifying the problem, coming up with the solution, that's not the hard part. As a matter of fact, that's kind of the easy part. The challenging part is how do you implement and deploy solutions, right? So take your pick on the right. Care team rounding, right? Daily huddles, right? Discharge planning, right? Let's plan for discharge at the time of admit, right? Using the lean tools to identify the keys to success and where processes must be captured, right, and information aligned. That's not the hard part, right? And so I like to give the example in manufacturing. When you set up a cell, you set up 4 or 5 machines. You put the machines physically in place. The machines themselves actually guide the operator's sequence. I put it in machine 1, I go to machine 2. Oh, machine 2 is right next to machine 1. So the physical layout itself actually influences and guides the behavior of the operator. Well, how does that apply in healthcare? It doesn't work at all, right? We like to say that whenever you have a process that you're going to be changing, one of the key questions to ask is how many people's behavior do you have to influence? If you're talking about an area that has 6 people and they all work in one place, implementation and deployment is not so complicated. If it's the admit process and you have 226 beds across 4 floors, oh my gosh, that particular process has to be implemented and deployed across however many beds, however many RNs, how many ever care teams. It takes nothing in healthcare for deployment to have to touch 90 people. It takes nothing in healthcare for deployment to have to touch 500 people. Right? In manufacturing, we never had to deal with that kind of math. Our scope of implementation, scope of deployment was always very narrow, and we had the huge advantage of the physical layout actually guided how the operators learned the new process and followed the new process. So a good rule of thumb, right, whenever you have a process change in healthcare, right, is think about how many people's behavior you have to influence, actually write them down by department and by shift, right, and then think about what materials we will use to implement and deploy the change. Right? So one of the phrases we use all the time is you cannot change behavior by email. The other piece that goes with that is verbal communication is 15% retention. How do we deploy and implement most changes in hospitals, in healthcare? Typically through a stand-up meeting and an email. Right? So when we wonder, right, why we struggle sometimes with sustainment, why we struggle sometimes with buy-in, when people push back, right, on what are seemingly good ideas, right? A big piece of it goes right into our strategy and the methodology for implementation and deployment, right? So please keep in mind, right? Identifying the waste isn't the problem, isn't a challenge. Learning the right tools isn't that tough. Identifying solutions actually isn't that tough either. The problem is too many organizations don't understand the criticality of implementing locally, deploying across shifts, or deploying across floors. And then, by the way, once you have a great solution, how do you scale those lessons learned across other departments in the hospital or across other hospitals in the system? Here's an interesting one as well. Respect for people. As everyone knows, right? There are those that are early to adopt and those that are resistant to change, right? I'd like to just point your attention to the yellow box at the bottom. Not all people learn at the same speed or learn in the same way, right? So one of the things we say is that almost all the solutions that you implement in healthcare, right, almost none of them are rocket science. As a matter of fact, they kind of all fall into the category of we used to do it that way, we sometimes do it that way, or we've been talking about doing it that way for years. That's interesting. Well, if many of these solutions already exist somewhere in your system, what has been the challenge to other people accepting and adopting, right, those great ideas that already exist, right? And again, it goes back to implementation and deployment. One of the things we say when we talk about implementing change in healthcare is when you really think about it, your people make very consistent decisions today, right? If you're in the same room as me, you see my left hand saying it's with some degree of awareness and understanding that your folks have, and it's whatever data and information that your folks have together, which in front of the individual, right, they look at and they make the best decision that they can, right? What's interesting is they make a very, very consistent decision, right? So for someone to say, make a different decision without changing my understanding or my awareness, without changing the amount of data or information in front of me, and yet you tell me by email to make a different decision, to the person who does the work, that makes no sense. What do you mean make a better decision? I'm making the best decision I know how. So the emphasis as you scale or deploy any type of solution, right, is how are you going to raise awareness and understanding? What information today are they not getting, but if they did get, would enable them to make a more complete decision, right? This is the piece to really focus on, right? And if you can build your processes, right, and your implementation and deployment processes to cover, right, those two dimensions, your opportunity to get those who are not in the room to understand what was decided and what was constructed in the room, right, will be significantly higher. And we'll talk more about that as we go on. PCMH, patient-centered medical home. Um, we all know what this is, right? But we all know that PCMH is the right thing to do, right? It's a shift of all kinds of things, right? From individual physicians and independent specialties towards a care team, right? We put the PCP at the center of care, or most of the time we do anyway, right? It's a focus on managing health, right, and managing illness, right, versus taking care of an occurrence or an emergent situation. It's intended to remove silos amongst various specialists. And the belief is that by improving health, we get an overall total lower total medical spend. And all this is true, right? We'll talk a little bit more about some nuances here in the next slide. But here's a question that I'm sure all you hospitals are facing right now. How does successful patient-centered medical home affect the hospitals in your community? Fundamentally, the size of the pie is going to get smaller, right? Most all hospitals in every region, right, are seeing the same thing over the last 3 or 4 years, whether for economic reasons or whether it be through true improvements in quality of care and in managing health. The overall volumes in the vast majority of hospitals are going down, right? We've already seen this in just the last 2 or 3 years. Imagine what occurs as PCMH really starts to take hold throughout more and more communities. These are the 6 different measurements or milestones of PCMH. Right, we all know them very well. One of the things we say is coming up with a goal or coming up with a plan isn't the problem. It's operationalizing the plan, right? That becomes the challenge, right? So we're going to talk about that here for a little bit. Why is operationalizing difficult? Right, we already talked about improvement is about both processes and people. When we say enhance access and improve continuity, if you don't have access today, right, in your practice or with your cardiologist, how do you build access? Here's something that's also interesting as well. We all know that we measure access, or many of us do, by time to third next. Is time to third next the right answer? Is that enough of an answer? For those of you who are involved in physician practices or have physician groups as part of your health system, test that, right? Check out your time to third, right? And then have someone do the old secret shopper thing and call in. Almost every organization we've worked with, time to third sounds like 6 days, 8 days, 4 days, 12 days. When you actually call, you get an answer that sounds like 2 months or 36 days. So although on paper, time to third sounds like not that bad of a number, the reality is, right, in real execution, for some reason, right, I'm getting answers very, very different. Identifying and managing patient populations, right? Here's a really interesting thing that's come up that's exposed itself. In the world of fee-for-service, and I know that depending what part of the country you're in, the degree of shared risk type of contracts or agreements varies. But in a traditional fee-for-service environment, how much resources are typically committed to population health and disease management? Right? I've always kind of struggled with that and said to myself, golly, I'm kind of surprised that anybody invested in pop health and disease management resources. Right? Well, now when we think about a shared risk, think about the processes that were key to success in a fee-for-service world. And think about the processes that are key to success in a shared risk kind of world. Think about the resources that are key to success in fee-for-service world, and the same thing as well as in shared risk. And what you start to realize is, wow, as my mix of fee-for-service, right, towards shared risk increases, well, let me say it in the right way. If I'm 95% fee-for-service today and that number is moving to 80% tomorrow or 40% tomorrow, right, what are the processes that are key to success? Right? What are the resources that are key to success? Right? And based on where I am today, how well am I aligned, right, to be to win the game of the future? Right? You'll find a very discrete mismatch there. Planning and managing care. You can see the bullet there, right? Knowing what one should do does not necessarily mean that you have the processes, systems, and desire to do it, right? So we view the shift away from fee-for-service as a great opportunity, right? And understanding what that means inside your organization and with your processes and with your skill sets, right, is actually a huge opportunity. For those that have taken on a shared risk, have recognized the opportunity associated with shared risk and have taken on that challenge or those agreements and have been able to identify the key processes and dedicate the resources. Shared risk is actually not a risk game, right? It's actually probably one of the biggest opportunities in healthcare game. Again, if you know what to do, if you know where to focus, and if you have the resources to do so. Let's see, provide care, self-care support and community resources, right? We like to say, what does good look like, right? So what processes and systems exist today, right? And how well do those align, right, with the needs of the future, right? When we say we're going to have telemed, right, or we're going to offer care by telephone, right? What does that mean, right? How much resources do you need? Who's your target audience, right? When we talk about things like pop health and disease management, the data has been around forever on what you should do for diabetics, right? And by the way, we've always been able to say to docs, all you have to do is go look in the system, right? And you know what you should do. By the way, then go look at your patients in EMR, right? Then you can go ahead and figure out who to call. One of the great lines we heard from a pretty large physician group was, you know what? Don't give me a 3-ring binder full of information and reports. What I need is the right 3 pages of stuff that's actionable, timely, right, and appropriate that I can give to my teams so that they can put that information to use. When you give me 3 pages of really good information inside a 3-ring binder of 100 pages, we're all just wasting our time, right? So again, as we think about the future, and again, integrate in the notion of health plans. Many of you get information today from the Blue Crosses, Anthems, and Cignas of the world, right? Think about the information they're giving you, right? And how can you either refine that information and or apply that information inside key processes, inside your hospital or inside your practices to help people, right, make a more informed decision than what they make today. Track and coordinate care, I guess I just kind of talked ahead of myself there. We've always known what we should do, right, for pop health and many of the disease conditions, right? Do we have the processes today? How will we monitor success, right? And, in saying that, yes, I achieved patient-centered medical home status, does that necessarily mean that you're getting the result or you have the processes and resources in place to achieve the result that was intended, right? So these are all just gaps, things to be aware of. Lean healthcare, some of the challenges, right? I already said this, but setting the goals, not the problem, right? Operationalizing the objectives is the challenge, right? And as the starting point of understanding where you are today and what you have to work with will absolutely affect the approach that you take within your organization, the pace of change that you can go with, right? As well as possible skill gaps and or process gaps that you have. We use the phrase mobilization model, right? So how are you going to mobilize things that you want to do, right? How are you going to educate your frontline leaders, right? Your middle managers, your directors, your executives. We talk about managing for daily improvement in healthcare all the time, right? Everybody loves huddles, right, in healthcare. My criticism of huddles, right, or my warning for huddles is be careful that it does not turn into quality circles of the 1980s, right, where you have a huddle for the sake of having a huddle, but in reality you have nothing to huddle about, right? So make sure, right, that when we're asking our people to do things, that we're giving them the resources, knowledge, and information to be successful, right, with those different tools. Remember, understand that it's through your employees that you're going to get to your objectives, right? So we get all kinds of reports. That's great. Reports are just numbers. We know we want the reports to. We know we want the numbers to get better. Okay, so at a senior level, right, we want numbers to get better. How do numbers get better, right? You can get there by manipulating numbers. That's obviously not what we want to do. What we really want to do is identify the processes that align with those particular metrics. More importantly, we want to understand the critical steps or critical tasks inside that process that are key to success, right? If we can understand, if we can realize the fact that moving numbers or driving improvement is all about behavior change of critical individuals inside the process, right? Obviously, the process changes as well, right? Then you'll begin to understand and realize what kind of resourcing may be required to get to whatever result that you want, right? Okay, so principles, systems, and tools, right, are the foundation. I'm swinging back around to the Shingo model, right? If all you do is you chase numbers, if all you do is you chase tools, if all you do is you chase events, if you do formulas and say this is how many events we have to do because the formula said so, right? You'll do a lot of stuff, right? But the risk is you'll be that first part of the bridge. You must be principal director, principal focused, right? Principles allow you to focus and align your resources. Developing the right systems, right? Systems guide behavior, right? So if you're not getting the types of behavior that you're wanting to get on the front lines or in the C-level suite, ask yourself what kinds of systems exist, right? And do those systems, are those systems there that help John understand what he should be doing, right? And then make sure you use tools in the right context, right? As you can probably tell, I believe they're overused all the time. Evolving reimbursement model, fee-for-service versus shared risk, right? I covered a lot of this already, right? It's fee-for-service, the payment model is very simple, right? People get it. Docs get it. As a matter of fact, docs have lived in this world for 30 years or 50 years, right? They know how the system works. They know how to win. They know the risks. When they hear things like shared risk, right? How do docs align? How do practices align, right? What does this do to hospitals, right? What we found is that practices and physicians, when they hear about shared risk, they understand the words. They understand they might get some money for it, but they really don't know what they should do differently, right? Before a shared risk model versus a fee-for-service. I touched on it earlier, right? To be successful with shared risk, there are critical processes and critical resources, right, that must be working in advance of illness in order to prevent the illness, in order to benefit from the shared risk payments. If I accept the shared risk payments and I don't understand the processes of the resources, I'm going to say, why am I not as successful as I want to be? What we found is that, again, in the traditional fee-for-service world is very, very well understood, right? For that audience, when you now throw at them shared risks, they literally get frozen in their tracks, right? What can we do to help them understand, right? What are the keys to success, right? And again, I'll emphasize that shared risk is a very big win proposition for physicians and physician practices, right? And okay, so the last couple slides here. Right, one of the questions again, right, as your health system, right, has new rules of engagement to play under, right, so what will actually change, right, what needs to change in order to be successful, right, and how will you help resource your organization so that they can have the ability to identify the right processes, work on the right challenges, and to implement the right solutions. I'm gonna say it again, and I know I'm overplaying it, but remember that coming up with the idea doesn't mean a whole lot, right? It's your ability to take that idea and that great solution and implement it locally, deploy it across multiple shifts, deploy it across multiple floors, right? And create a process that's effective with scalability that will translate into speed to value for your organization, right? You don't have to do a lean event in every single department in order to fix wait time, as an example. Just keep in mind as well, what are the skills that will be key to success in the future? And remember that changing the metric alone is not going to result in meaningful change in your organization, right? When you change a metric, right, now the challenge becomes which processes should most likely change in order to support that particular metric. Think hard for all your hospital systems out there, or health systems out there, right? What does the expansion or the shift away from fee-for-service really mean to you? By the way, if you're at 92% census, what does it mean to you? If you're at 65% census, what does it mean to you? Right? These are the impact on a hospital that's at 65% census, right? And all of a sudden shifting away from fee-for-service coming into play as well. Should be pretty scary, right? What types of capabilities and what do you have to do to prepare for the future? Here's a common one we find. This again is extending the value stream. Hospitals tend to think, one of the challenges in healthcare or with hospitals is the phrase, everybody thinks they are the value stream. I am ED, I am the value stream. I am lab, we are the value stream, right? I am OR, we are the value stream, right? A good rule of thumb is to say to yourselves, force every value stream to start at primary care provider and end at primary care provider. And it'll help your organizations or each of your projects or event teams not get locked into sub-optimization. Okay. Are there things that you can do, right, to help accelerate or accentuate, right, the learning process inside your organization, right? Where you know, right, how you can be successful. And again, I'll use the fee-for-service change to shared risk. How can we take what was learned and share it with the others who haven't yet learned it yet to try and reduce that stress level, help people understand and accelerate their learning process, and help them to start get mobilized on improving the right processes. Why lean or OpEx in healthcare? You can read this right here. When done right, it can do really, really good things. Right? I have a quote down at the bottom there from a friend of mine out in Helsinki, Finland. And I asked the question, right? Should we have needed lean to implement these things that we implemented during this particular project? And Tuomo said, please, can I answer that question? He said, John, I've worked at this organization for 27 years. He said, if we had the will and the desire to implement these changes, we would not need this thing you call lean. However, if lean gives us the will and the desire and the focus and the attention, right, to actually implement these changes, then we need lean. He said, John, everything we did this week, we used to do it this way, we sometimes do it this way, we've been talking about it this way for years. It was during this process that we actually got the attention and resources to focus on improvements. He said, we need lean at this organization, or we don't have the attention span to get the right resources. One last slide here, talking about, again, bring it back to the Shingo Prize and the Shingo model, right? How do you move, right, towards a bridge that's holistic and complete, right? Number one, understand the relationship between principal systems and tools. Leverage or utilize systems to encourage and drive the right behavior, right? And use measures to monitor, right, the progress that different teams have made and celebrate success. With that, I didn't do too bad. I went about 10 minutes long. I'd like to open up for Q&A if there's any out there today.
Awesome. Well, first, thank you very much, Mr. Kim. That was a fantastic presentation. Right now we have it looks like just one question so far. If anybody else has one, type them up and we'll cover it. Right now we have a question from Pedro Rodriguez. He asks, is it possible to implement lean concepts when you have no stability in your sources, material, methods, machine, man? Do we need to be in control mode before lean implementation?
Well, Pedro, great question. And there's actually two questions there, right? First one is, can we mobilize lean even though we're not in control of our sources? Absolutely, you can, right? One of the challenges when you have noise at the front end, right, is that the more noisy the front end is, the less in flow you can be downstream, because you have to find some way to deal with the noise that's upstream. So an example being a peri-op process, right? Let's call it outpatient surgery. And today, right, we have a lot of noise from the 43 practices that feed the peri-op process. Should we not, or can we improve the peri-op process even though we haven't gotten to the physician practices yet upstream? Absolutely, you can, right? The types of waste that you go after, the approach that you'll take, and the metrics you can impact may be influenced, right? But don't think that you cannot begin because you don't have a perfection upstream. The next piece, I guess maybe it is linked, right, is do you have to be in control mode before you begin? No, not at all, right? Once again, it's a similar question, right? If you have perfect flow, right, 1 = 1 and everyone's performing to takt time, right, for that example, right, then what it means is you can operate in a very low waste way type process. If upstream, we're still kind of noisy, what it means is we're going to have to come up with some sort of process to isolate the noise upstream from downstream. So it could be, say, a Kanban, right, that in OR, depending on the surgeries coming into play, we need a certain number of tool sets for knees or for certain knee or certain type of hip. We don't know what's coming in, right? Well, if we knew exactly what was coming in, we could design a process that was a one-for-one. If we don't know what's coming in, oh, what it means, I might have to use another lean concept or lean tool to still achieve flow. It's just that my perhaps work in process inventory, instead of being 1 day's worth, might be 1 week's worth.
Okay, excellent. Thank you. Urban Wimerlov asks, what is the best way of sharing learnings?
That's a great question. Probably one of the biggest takeaways and lessons learned about working in healthcare, and we'll say hospitals, right, for what, 10, 11 years now, is, oh my gosh, right, so many of the learnings, right, can be shared from one location to another. So we call that process knowledge transfer, right? And then, of course, you can't transfer knowledge unless you've captured knowledge, right? So somewhere along the way, right, those who are on the project team or event team, they have to document their journey somehow, right? And so we use a thing called closeout reports, right, where we use the phrase, if it's not written down, it never happened, right? And if you don't take the time to write it down during the course of the project or the event, when will you ever write it down? You won't. So something that we use, these closeout reports, right, will be 22 to 28 slides. Starts with a problem statement, the desired state, that is the charter, and it captures like a cartoon strip, right, the things that the team learned along the week, right, if it's an event, or it could be along the course of the project. And you actually write the closeout report with the intention, I'm sorry, with the objective of not of the people who are on the team, but people who are not on the team, right? So those who are on the team, oh, they were there, they understand a whole lot, right? Well, have that team take the time to capture their journey, their lessons learned, and write it from the perspective of people who are not in the room. Once you have it, you can scale it. Once you have it, you can share it. But if you don't have anything to share, we use the phrase, all you have is folk stories, right? Verbal communication, 15% retention. What did you guys do in that event 8 months ago? Oh, we did a lot of stuff. Let me try and remember, right? So that's probably one of the biggest lessons learned as well, right? Is take the time to capture the journey. Yes, it takes some time, right? But if you take the time to capture it, you now have something portable that you can take to different units and get people to look at it and say to themselves, huh, I never thought about that way before, right? And by the way, now you have a foundation or a grounding for shared lessons learned and common understanding. And then if there's also additional questions, not a problem, just go to the area, right? But instead of showing up the area and saying, what did you guys do 6 months ago, and someone having to take 45 minutes to show you, you can take the closeout report, share it electronically. You're not going to get 100% knowledge transfer, nor do you need it. I'll take 20%, I'll take 50%, right? And then from that 50%, now I want to go see. And when I go see, right, the dialogue between that supervisor and myself or my team will be much more effective for everyone.
The next one is from Marcio Mariano Jr. How do you motivate physicians into lean? We have a few questions now, just to let you know.
That is, I thought about building a slide on it, but I knew I'd spend all day on it. I can tell you that when we first started doing lean in hospitals, right, we did it the typical, the way that most people did it, and that is the value add is the care provider, either nurse or doc. We were afraid of the docs, right, so we focus on the non-value add in between the steps, right, and by the way, that works quite well, right. We were challenged, I think 2, 3 years ago by a client who said, John, if you want to do it that way, we're not going to do it, right? And we were challenged by the CEO who said, we are a physician-led organization, and physicians ultimately make the critical decisions inside our value streams. If we cannot mobilize this, right, through the physicians, right, I don't want to do it. And I said, do you really mean what you say? He said, absolutely, right? Because of that client pushing our envelope, we will now never recommend mobilizing in any hospital, any SNF, any physician group without it going to the docs, right? So the question around how do you mobilize with the physicians and providers? Well, first of all, you better have your stuff together, right? So the notion, I've used all the same phrases as well, right? When you've convinced one doc, you've convinced one doc, right? And now I don't like to say that, right? Because what we've realized is although you have to deal with the docs' schedules, and yes, it's been a long time since docs have been told no, and yes, some of the docs' egos are pretty big, right? All of those, right, in hindsight, are just excuses to not involve the docs in probably the most important thing in their lives as well, and that is the work environments and processes that they work in, right? So the answer, unfortunately, is long, right? But I would start with, you know what? If you're avoiding the docs today, you need to turn that off, right? And you need to stand back and ask yourselves the question, how do we engage the docs, right? We have found that physicians and providers, they absolutely respond to facts and data. Absolutely, absolutely. When they see that their uh, referral to cardiologists, PMPM, med expense PMPM, I'm talking health plans here, is $16 higher, right, than their colleagues. The first thing they say is, why am I $16 higher? Right? Now, by the way, if you're showing unprepared, if you show up with just the opinion of you can do better, you're not as good as the other guy, right? Then they're going to eat you up, right? But I would encourage everybody to stand back and look in the mirror and say, you know what? If we're struggling with our physician engagement today, and we tend to do lean avoiding the docs versus working with the docs, right? Ask yourself the question, right? What would it take for us to be successful with the docs, right? And work that direction. Okay, so number one would be make sure you have facts and data, make sure you involve them early. You do have to respect their schedules and their times, right? So the old traditional, if you're not here full time on a lean event team, you can't be on the team, that goes out the window too, right? We work with docs all the time, right? Where we get 2 hours here, 2 hours here, 2 hours here. Implementation deployment is key, right? One of the things we say whenever you have a process change, you must first describe the why and the what's in it for me before you dare tell them the what, right? So if you think about, again, this is about implementation and deployment, and you're going to roll out a process change, right? Remember, verbal communications, 15% retention, cannot change behavior by email, right? When you roll out a process change, right? We literally, I can tell you that 3 weeks ago, right, to help coach one of our clients at a hospital system how to communicate to physicians and engage physicians, I'm sorry, and deploy to physicians. We went eyeball to eyeball, 19 meetings, 26 providers, right, going in and explain to them the why, the what's in it for me, and then the what. I can tell you that all that the 24 to 26 docs, no problem. They understood it. They say, thank you for explaining. I can work with that. Now give it a try. We had a couple docs, right, who were very loud in conversation, but at the end of the day, right, they said, I understand, right? So it is about methodology. There is a piece of respect, right? But don't be afraid of it at all.
Okay. Karen Schaefer asks, your comment that you learn by doing is overdone. What learning methods do you propose?
Great question. Um, knowledge capture, knowledge transfer, right? So here's what's interesting, right? And we've had the opportunity now to work at well over 100 hospitals, right? The last 20 of which we've had this knowledge capture, knowledge transfer methodology in play. Think about if every project that you worked on, that there was a storyboard, there was a cartoon strip of 22 to 29 slides. An outsider could take that storyboard and look at it and say, huh, I understand what they did. I understand the process. I understand the tools they used. I can see the waste that they identified. And I can see why they chose to focus in on these two process changes or going after these two or three types of waste. This makes sense, right? If it's written down, I have the opportunity to glean from it and learn from it. If it's not written down, how do you learn? Right. So one of the huge things about knowledge transfer is all of our clients wind up setting up some sort of SharePoint site. That SharePoint site winds up being the knowledge hub for training materials, for A3s, for these closeout reports. Something else to think about as well, right, is when you have 4,000 people at a hospital, right? If there's an inquisitive mind, where do they go to learn more about lean? Right? And think about the process or the infrastructure you have or don't have to help people learn more when they want to learn more, right? So learn by doing is the example of being on an event, right? The fact that you don't have to learn everything by doing means there's someplace else I can go to learn, right? So I've talked about this goes out reports. I also want to encourage the Healthcare Value Leaders Network, right, and the tours, the workshops that they offer. I want to encourage you to attend the IHI conference, right, coming up in December, the Shingo conference coming up, I think, in April or May next year. There's an incredible environment of learning, which is so different. Actually, the learning environment did not exist in the mid-90s, right? So the resources available today are 1,000 times more than what was available in the mid-90s, as many of us were learning.
Fernando Garcia asks, how long does it take to implement the Shingo model?
Fernando, you sound like typical American. When will I be done? Right? That's a great question. The answer comes right from the structure and infrastructure you have in your organization today. What is your starting point? And depending on your starting point, your velocity of change, right, and appetite for change from your executives, you're gonna get some different answers. So I don't mean to dodge your answer, but if you're a high-performing organization today who does many, many things very, very well, we have a client who has the best OFI process I've ever seen in my life. Opportunities for improvement comes out of Baldrige, right? As a matter of fact, the OFI process they have is in every department. It's active and daily, every day, every other day by the different department teams, and is an incredible way that they capture ideas from the floor and that the floor implements and implements solutions and captures and shares lessons learned. Right? When we saw that, we said, "Oh my gosh, right? We should modify our process to take advantage of this OFI capability." Right? Now, the other pieces that are a bit trickier, Fernando, I'm not sure if you're an executive or middle manager or front lines, is what's the appetite for change from the senior executive team, right? Because their appetite for change will translate or correlate to the kind of commitment and resources you get, right? So a little bit of what's your starting point, a little bit about your internal capabilities to mobilize and implement change, and a lot bit to do with the senior executive involvement and commitment. Those are probably the three ingredients that you and I would sit down and have a conversation about to see how it fits.
Okay. John Bushling asks, how do we overcome leadership lip service to lean implementation versus involvement?
Wow, great question, right? The first thing, I guess I'd start that with the phrase, don't let them run and hide, right? You guys go do it, I shall go over here, right? Here's another example of a client teaching us lessons learned. We used to do training of executives with executive training and training with directors with director training and training with frontlines training and some supervisors. They challenged us and we did training by vertical, right? Within a service line, so to speak, if you want. When you train by vertical, right, then what you wind up doing is creating common language from the front lines all the way to the top. It sounds like you already have some experience with lean, so you already know the mistake that can happen when an executive who doesn't know what they're doing or what they're saying walks to an area and says, "What happened here?" Right? They kill all the momentum, they kill all the enthusiasm, and they didn't even know they did it. Right? So the most important thing with execs is to get them involved early. Our methodology says it's from the top, right, that they establish what we call the business case for lean at that hospital or at that clinic or at that organization. When they themselves pick the business case for lean, right, we say things like, if you could pick any 3 metrics to improve by double digits in 12 months, what might you pick? Maybe it's patient satisfaction, maybe it's quality of care, maybe it's revenue or growth of cardiology, right? So maybe it's cost, I don't know, right? But when they pick their metric, right, you can now align your methodology to their objectives, right? And when they pick things that sound like cardiology, right? Our cardiology, we're 14% below budgets, right, in cardiology this year. Oh, well, now we know what the objective is. Let's take revenue and let's improve cardiology. You can then look at the value stream of cardiology. I don't know your hospital, but I suspect that you're going to be very similar to what we find in a lot of the hospitals we work in, and that is the potential bottleneck or the potential constraint in growth of cardiology ain't in the hospital. It's going to be out in the physician practice, and the fact that they're currently seeing new patients in 6 weeks. If I have to wait 6 weeks, I'm going to Cleveland Clinic, right? So, the short answer about how do you engage executives, right, is by start with their business case, when you pick their business case and align your program or your resources to their objectives, they're naturally inclined to want to follow. And then as you mobilize and as you deploy, you need to make sure that executive training is as much as part of the mobilization plan as frontline process changes.
Okay, there are a few more questions, but we are out of time. So I apologize to those questions that we didn't get to. And I want to thank you, Mr. Kim, once again for a fantastic presentation. This presentation will be available to view tomorrow on the Shingo Exchange, www.shingoexchange.com. Thank you again, Mr. Kim. We appreciate it, and hopefully we'll do this again sometime soon.
Very good, Joby. If you want to capture those questions, Joby, send me an email. I'll write responses and we can post those as well.